Good morning and welcome to the 19th Annual World Congress for Brain Mapping and Therapeutics. This is our fourth day and we are honored to have our first keynote of the day, Dr. Amin Kassam, one of the pioneering neurosurgeons and member of our Society for Brain Mapping and Therapeutics board. He's also recipient of 2022 Pioneering Technology Development Award from the Brain Mapping Foundation, which was presented to him during our gala. Amin is really a game-changing neurosurgeon. Many of his ideas have turned to become cutting-edge companies, like some of his patents and ideas are the base for a company called Synaptive, and similar ideas have turned, great technologies into a company like Neeka. So with that, I'm delighted to welcome Dr. Amin Kassam. Dr. Kassam going to be talking about basically learning from our patients and patients as our best teachers. So Dr. Kassam, welcome, and please go ahead and start your lecture. Thank you.
Thank you so much. Wow, what an honor. I'm incredibly grateful for the opportunity. Before we begin, though, I think it's always important to take a minute just to thank those that have gone before us. And I'm indebted to Wolfgang Groff, who was a wonderful mentor and a friend, Professor Roten, and certainly Heinz Stammberger. And while they've all left us, everything we do is owed to them. What I wanted to share with you is kind of the evolution of the things that we've learned from our patients and how technology has impacted that in a meaningful way. My career has really been 10-year blocks, and the first one began with endoscopic surgery. We took a great deal of time to learn from our first 800 patients, looking at the complications associated with it and understanding how anatomy coupled with technology really created the procedure. And so in the first 800 cases, when we looked at it, we looked at the outcomes, what we found was that our complication rate was about 2.5% overall. When we started to understand these complications, we thought they were going to primarily be vascular, but in fact, they were related to cranial nerves. A big issue became the idea of visualization, what we were seeing in the absence of technology in the early 2000s. We were really in a tech debt back then, and what we needed to focus on was enhancing that. Visualization was the key, and this developed this whole pursuit of the work that Babek did, which is understanding the white matter, its corridors, but more importantly, visualizing it with optical visualization systems. And I want to touch on that a little bit as we go. So when we looked at these outcomes, we compared the first 800 cases that we had in endonasal surgery that was published as Professor Jain published this as the cover of a JNS article. What we found was that our complication rate was about 5.4% overall in level 5 procedures when we were lateral to the carotid. So we thought the carotid was going to be our major complication. This is a particular patient that's extremely dear to me, that changed the way I think about endonasal surgery. In fact, the way I think about surgery. Large chordoma in the ventral skull base, as you see, that was a recurrent redo chordoma, very difficult to access with the basilar pushing it back. When we got inside, we wound up with identifying the carotid, and there was a carotid tear and a laceration. This was my first carotid injury in my career through the nose. It was when endoscopy was very early. You can see by looking at the video, this is CRT, poor low definition video. So this was, gosh, over 20 years ago, 2 decades. This structure here, we found in order to get control of the carotid proximally. And it looked like a wedge. So I named it the pterygoid wedge. I'm holding the carotid together here with my left hand while I'm trying to get proximal control of the carotid. Drilling the wedge off gave me proximal control. You can see now I have a tear in the vessel, but I have enough tissue to be able to weld the vessel together. So make no mistake about it, this is a carotid sacrifice. In this particular case, you can see how poor the visualization is. The optics are less than ideal, but there's enough tissue. This bipolar had just been developed for endonasal surgery. It didn't exist. We worked on it for a little while to optimize it. And now I'm sealing the vessel. Blood is a tremendous heat dissipator. I'm forcing the blood into the sucker while we're converting this large hole to a series of small holes. And that allows us to isolate and close the vessel. Eventually, we were able to stop this. In God's grace, we were very blessed. She did quite well. We were able to resect the rest of the chordoma in this particular case. This led to a journey that lasted over 4 years and actually didn't get published for almost a decade. I wanted to really understand the relationship of the carotid. So we went back to the lab, identified the parapharyngeal, the horizontal segments, the respective landmarks associated with it. That single case with the pterygoid wedge identifying the location of the video nerve, which then became the key landmark. That was the genesis of that single patient telling us that we needed to get a better idea of what the carotid looked like through the nose. It then led to the paraclival segments and what you now understand as the paraclinodal segments. Each of the respective 6 segments we were then able to identify and create landmarks. So this was the translation of a complication, a patient, back to the anatomy lab, and then the technology that led to the development of the parapharyngeal all the way up to the paraclinodal carotid segments. That led to this concept of a sagittal plane working in between the carotid as well as a lateral plane. And what I want to emphasize here is how from the patient, the process to the anatomy to the technology was the evolution. It's the same process we followed for 20 years. The modular approaches were built exclusively based on that single patient. And so what we really needed to understand is this concept of a neural network. When we dug in and started to realize the complications, we understood that there was a neural network, both intraaxial, referred to as the white matter tracts, and then extraaxial, which was really driven by the cranial nerves. The cranial nerves became the predominant source of complication. In fact, what we learned was in the first 2,000 endonasal cases that I've personally done, we only had 2 carotid complications, God's grace. 2 in the first 1,000, and God's grace, none since. So what was really the major complication that was driving morbidity was the neural network, which in the case of skull-based surgery was the cranial nerves. Now we needed to find a way of visualizing it. And then as we transferred this concept to the white matter, we had no mechanism of in real time being able to see the white matter tracts in a pragmatic, real-time application in the operating room. We started with the role of the cranial nerves. We published a variety of papers. So now we've gone from a complication to an anatomic understanding to technology to identify novel procedures and then documenting them in iterative fashion through the literature. The concept of the ventral cranial nerves became the driver in skull-based surgery. We took a sagittal plane axis, divided it along the midline, and then anything that is ventral to the DRES of 5, we said really lends itself to an endonasal approach. Anything that's dorsal to the DRES of 5, we felt should best be done to a dorsolateral approach. We started to see additional complications early in our experience when we were first learning that completely transformed the way we think about surgery. This is another patient that very, very early, I was doing a craniopharyngioma endonasally. I moved into the cella and then tried to access through the suprasellar space the craniopharyngioma. And when I did, we wound up with a small P1 perforator tear that created a small thalamic infarct, and the patient developed aphasia that eventually recovered. I promised myself that day in the early 2000s that I would never approach a craniopharyngioma in the retroinfant indoor space that way. It was a definitive event in my career. And so that led to this whole concept of a pituitary transposition. And rather than reaching behind into the P1 through a suprasellar approach, it led to this concept of taking the pituitary gland, understanding its embryology, and mobilizing it. And then the 3 types of craniopharyngiomas endonasally that we described with a transplantum approach, a transplantum with the suprasellar superior intracavernous sinus approach, and then eventually with what eventually became the pituitary transposition, which was almost a 5-year journey. We postulated that there must be such a thing as pituitary ligaments, went back to read the embryology, and identified these mesenchymal bands along the lateral wall of the pituitary, identified the diaphragma. But this could not have been done without a major evolution in HD optics in endoscopy. The optics in the operating room allowed us to start to see this visualization. The CRT optics weren't going to work. High definition now came into play. And we started to see things that we hadn't seen. And when we did, we conceived of this idea of the pituitary transposition, elevating it, doing shoulder osteotomies in the dorsum. And here, the hours and hours of cadaveric work that went into this. This is in India with one of my close friends, Nishit Shah. And you can now see the retroinfundibular space and the visualization into the third nerve that gave us views into this. We translated this back to the operating room, and now here's a suprasellar approach. We needed to understand this idea of opening the diaphragma in order to release the infundibulum. Look at the difference in optical visualization over that 5-year time. So we've gone from a CRT to an HD visualization. We can now identify that, in fact, there were 2 layers of dura. We could identify the lateral wall of the gland. This was forced by a technological evolution that occurred in optics, and we're very grateful for our optics partners. And here now you can see pituitary ligaments that we didn't know existed. They were always there, but in the absence of technology, we hadn't visualized them. There's a beautiful ligament here that now needs to be cut and mobilized, and that gave us these great views into the pituitary that we were able to lift. And you can see the medial wall of the carotid. So when I first started to do these pituitary transpositions, they gave us unprecedented views. We were able to identify critical landmarks like the middle clinoid. That was published. One of my good friends looked at 2,000 skulls in a museum and was able to confirm the relative position of the middle clinoid, which became a consistent landmark in order to isolate the carotid. The point here is that, in fact, the complication that we had led to this, really what turned into, in this case, a 7-year journey to identify these anatomic structures, and the technology allowed us to visualize them. This led to these extraordinary views now into the suprasellar space. And once we got these mobilizations, we now, for the first time, now incorporated the next major visualization. If you recall, I was so worried about the cranial nerves as being our primary source of complication based on what we learned from the patient. So we started to do DTI and CSD visualization, actually visualization of the optic nerve here in real time, image fusion with bony and vascular imaging, coupled with voxel to voxel integration of the actual anatomy. Now you can see the third nerve complex here. There's the optic apparatus and the bony apparatus and the architecture. That gave us these extraordinary views and windows and corridors that now allowed me to access directly into the recesses of the third ventricle from endonasal approaches. And here you can see there's a little bit of tumor that I've left that otherwise I would have taken, except with this great visualization, as I start to see into the foramen of Monroe, you can see that the medial wall of that little bit of tissue is in fact the hypothalamus. And when I flip it over, that would be easy to cut, but I would create a hypothalamic syndrome. Without the technological evolution in high definition optics, as well as the fiber tractography, I'd never be able to get there. And we're gonna visit this hypothalamic region again. So that single patient with that P1 thalamic perforator changed that. And now you can see, I can now see the perforator, the very perforator that I tore about 15 years ago. I can now see because I was able to transpose the pituitary and make a single cut here to isolate the portion of the cranium that I otherwise would have reached over the top of the dorsum to be able to access. I can now see it and undertake sharp dissection. And just beyond the tips of the scissor, you see the third nerve. And that's the evolution that that particular patient showed me. So this led to a pituitary gland transposition. Gland preservation rates was shocking. It was 87.5% at 30 days. What we then eventually evolved into was this ultimate expression of skull-based surgery in my mind. The dorsal approaches really extend and are driven by the cranial nerves, the anterolateral corridor, anteromedial, anterolateral corridor that goes from the glabella to the supraorbital fissure up to the middle fossa to the jugular foramen, and then the jugular foramen up into the region of the foramen magnum. These are all exposed dorsally as long as the nerve is located ventral. Contrary, if the nerve is located ventrally, we come from a ventral approach. So we don't want to cross the plane of the nerve. And this is the anterotransplantum transcribiform approaches endonasally. These are the anterolateral supraorbital fissure approaches. And then these then become the coronal plane approaches into the middle cranial fossa, and then the juxtatubercular approaches that we described. So this is my approach to the skull base using an osseous bony aperture, but is actually driven by the relative position of the nerve. The short answer is, if the nerve is located such that it is dorsal to the lesion, I'll come ventral. If the nerve is located so it's ventral to the lesion, I'll come dorsal through these modular approaches. These concepts were beautifully dissected by Alejandro Mineral-Soso and then recently published in a book, including intracranial as well as white matter opportunities. We then focused on visualization, feeling that we had kind of exhausted the endonasal approach with optics. I tried to bring the endoscope into neurosurgery in the late 90s. I really tried hard in the early 2000s to take the endoscope and try and see if I could bring it into dorsal transcranial surgery. And it just didn't work. The visualization was poor. The 4mm corridor didn't work. But fundamentally, the problem was that the cisterns in the brain were packed with cranial nerves, and navigating around them didn't make sense to me. The nose had sinuses, so the scope could move around in air. The brain had brain, and I couldn't move around them. So I realized pretty early, by the late 2000s, that what we needed to do was to develop the next generation optical visualization system, an exoscope, and started to focus that on 2009, and really abandoned the microscope in 2015. So I've not used the microscope in my practice now for 6 years, and the evolution from endoscopy in 1997 did not translate to the brain and forced the evolution of exoscopy as a technology development. And so why did we do this? This led to the robotically operated video telescopic system that I currently use. The reason was the depth of field was what we were trying to drive. In order to develop and preserve a high depth of field, an optical payload was required that had a numerical aperture that approached 1. And that gave us these extraordinary depth of field visualization despite high magnification. And that's what we were trying to look for. And this is a really nice example. Endoscopy creates a light pattern that is essentially a flashlight effect. So you get a wide field of view, but your depth of field shortens. What we were looking for, and that gives you these views, in this case, the 6th nerve with great visualization, but you lose the 9th and 10th nerve and the 5th nerve around it. And what we were really looking for is a wide field of view that was preserved and a depth of field, optimization. So we wanted to move from this idea of convergent light that moved into divergent light in endoscopy to parallelity of light. And that required an optical physics platform that really focused on creating a numerical aperture that approached 1. This was a difficult journey. It began in 2009 with a single component of the optical chain as a payload, but then really required robotic integration with a navigation system that allowed you to keep parallelity of light so you didn't lose light. And it was transformative. So in this case, rather than just seeing the 6th nerve, I could see the entire posterior fossa complex with a field of view and a depth of view, creating this concept of a volume of view. So rather than just seeing the position of the relative clip of an aneurysm with a microscope, I can actually get a cubic volume of view with all components of it equally preserved. And I can get an X, Y, and Z axis rather than exclusively a point, moved away from a focal point to a volume of view. This was a transformative event for me because it allowed us to create what in the operating room now became a cockpit, as you see. And the robot would move with us through a computer-machine interface and now voice activated, and hopefully one day or retinal activated that can go to the position that you want it to in real time. The operating room transformed into really a cockpit with multiple viewing screens that were seen simultaneously. And now we're going to look at the posterior lateral corridor and its application. Perhaps the most congested area is the juxtacondylar space that requires depth and field of view simultaneously. When we started to look at this, you can now see the kinds of views that are preserved. So you can see the paramedian planes are preserved as we start to dissect. Look at the wide views and the depth in the space that you're able to see. We then focused heavily on Babette's work, and he really was the absolute pioneer in this space, was to see if we could track the neural networks. So what we wanted to do is see the combination of cranial nerves coupled with the white matter tracks. And you can see I'm sitting in a very comfortable position with the robot over my shoulder. And now I'm starting to dissect out the vertebral artery here. But as I'm coming to the juxtacondylar space, I can see the 9th and 10th nerve complexes in real time, get a look ahead. I can see the jugular foramen. Here's the jugular tubercle after a mastoidectomy. In fact, I can program the 7th nerve and 9th nerve into constraint boundaries and then drill aggressively until I get to the constraint boundaries. Using the optical visualization system, and in this case, a large schwannoma, I can see that the nerves are actually ventral to me, so I can come through a dorsal corridor. The field of view is preserved at 5 centimeters, which is shocking. The robot moves in real time. So I can get a depth of 5 by 5 by 5 centimeters with mobilization of the optic apparatus within the robot. In fact, in this case now, I can, knowing that the cranial nerves based on tractography are ventral, I can now approach this dorsal. So I'm actually opening the tumor in the jugular foramen first, debulking it, and then coming back into the posterior fossa after that. And here's the vertebral and pica complex that I can now see. The schwannoma can easily be resected and debulked. But what I want to show you is I'm doing it with real-time tractography, locating the cerebellar folia, but more importantly, the cranial nerves, 9, 10, and 12. Once I get inside, I can now start to mobilize the space, and then I can start to use multimodal imaging coupled with a robotic optical visualization system. So here's the 7th nerve, and you can't hear the volume, but as I start to do this, I can couple this directly with neurophysiological monitoring and actually see the patterns. The visualization is actually shocking because there's no need to change the focal length. And as you can now start to see, I can see 7 quite clearly. 8 is now visualized very well. And I'll get this panoramic view of the posterior fossa in real time. This allows me micro dissection even at this, look at the depth of view that I can see. So now I'm seeing 8 and its entire course of 7 below it. Okay, I just was not used to seeing this kind of visualization, a small branch of the artery, and here's neurophysiological monitoring. So now we're doing multimodal, and I can obtain a threshold down to 0.7 in a single view. Ultimately, what I wind up with is a very panoramic view of the entire posterior fossa, as you see, coupled with neural monitoring and then tractography. So this is the final view, as I can see, from the 12th nerve to the tentorium. So from 4 to 12, all in one view without the need to change the focus. That was a transformative event for me in skull-based surgery overall. Eventually, what we wound up with is wanted to transfer these concepts up into the white matter. And that really became our ultimate goal. So what we found was, at the end of the day, my entire career came down to this idea that the white matter and cranial nerves are the same thing. This is the exophytic neural network, and this is the endophytic neural network, which is the subcortical white matter. Starting in 2010, I became passionate not to replace skull-based surgery and cranial nerve concepts, but I became passionate to incrementally add the concept of tractography and white matter surgery. It really became a fundamental passion. Just as I'd spent the bulk of the 2000s in the lab trying to understand the ventral skull base, I spent 2010 through 2015 in the lab trying to understand and map the white matter from a conscious perspective, thinking that the planes could not be crossed because the nerves couldn't really manage mobilization, nor could the white matter. So we wanted to create this intraaxial component to it. This led to a series of dissections that Alejandro Monroe-Sosa, who's the most talented white matter tractographer and dissector that I've ever seen, and is now the chairman at the University of Mexico. I'm so proud of him. In our lab, started to focus on, and we created what eventually in 2017 became the White Matter Surgical Atlas as a planning surgical corridor. We've done over 1,000 white matter cortical planning cases that Melanie Fukui, who's our radiologist, has built. And in the process, we identified a new white matter fascicle that previously had not been reported, which was a branch of the SLF architecture. And what we realized that it was critical for apraxia. So I'm going to show you an example of how we started to access it. So here is a meningioma in the trigone. We moved over to conscious surgery, where the patients receive a little bit less anesthesia than colonoscopy. They're fully awake. As you'll see here, they're never really taken down, and incisions are done through a small block. So rather than approaching this to a lateral approach where the vertical component of, the occipital radiations would be at rest, and rather than approaching this from an interparietal approach where this particular fiber that we call the vertical rami would be at rest, we started to develop new corridors. So historically, our corridor to this would be the interparietal sulcus, which we thought would really damage the vertical rami. And we moved this into a region of Jensen's sulcus and into the parietal occipital sulcus posteriorly, and created a new entry point that would preserve this region in particular. And we focused on that. This was the white matter map that each of these patients get in real time. We're able to then preserve this vertical rami that was the key. That really became the key.
Progressive lateral dissection.
So we started to move away from the vertical rami and came into this region more posterior using 3D tractography. So in this particular case, what I want to show you is how it changed our approach. So there's the incision. It's a relatively small incision. We can use VR to superimpose this directly on the patient's head. And then as we get into the operating room, the craniotomies are relatively small.
And the epicenter of the sulcus is now identified.
The dural openings are extremely small.
Exclusively to the predefined entry point, specifically the intersection point defined.
We then work with our partners in the robotic visualization
depth
system.
of the sulcus is not
we're going to preserve this
in any way.
We're not going to transgress it. We're not going to bipolar it
against abrasion during.
And then we work with our partners in Neeka.
At this point, cannulation
to then create
by
a traumatic cannulation.
Which the sulcus was open using dynamic navigation. And
actually would preserve the vein. The idea that you could cannulate, preserve this vein, and not injure it, and put this big blue tube was about a decade's worth of work that Joe Mark did amazingly well. Eventually, we're able to get down to the base of the tumor, and what I want to show you is what happens to the patient. So I'm going to let the video and audio run here for a second, but to orient you, this is being done through a 13-millimeter tube in and around the ventricle. We've now accessed this. The optic radiation is located at 12 o'clock in the vertical rami. When we do a neurocognitive testing on the patient, listen to the patient from stereoagnosia in real time.
As well as dyslexia and acalculia.
Read the following words out loud and tell me which one appears twice. Truck, shoe, bar, clip, shoe, slide, shoe.
Completely normal pattern, no dyslexia, no dysrhythmia as we start to work. As I start to roll the tube around, you'll start to see that I create pressure upon and manipulate the vertical rami.
12 to 3 o'clock position.
As I start to manipulate the vertical rami, listen to the patient's speed and processing.
As well as vertical rami with cognitive processing speed reduction. This is because the tumor is firm and fibrotic, creating compression of the optic radiations in vertical rami with deficits noted in the patient.
The dog pecked at the bread.
Okay, so that takes me some time to just read it.
It's because it's sort of like pecked at the bread. You know, bread might be. I'm seeing. Let's see. What am I seeing? I'm seeing pegged at the BREDREAD. You know, it's a.
So what you realize right away in that particular patient that it became extremely scary because the patient started to develop a stereoagnosia, a speech difficulty, as well as a dyslexia. This is the typical apraxias that patients with interparietal syndromes wind up with. And you can see here, it's when we start interacting with these fibers in the bottom lower quadrant of the 4-quad panel. When we started to then readdress with this completely conscious patient, we saw an improvement in the fields as well as the agnosia. We were then able to take this out. And at the end of the case, you can see the vein is preserved.
The combination of the patient's neurocognitive examination is significantly improved so that the patient
the brain path works
at a much faster pace.
And listen to the pattern.
Read the following words out loud, then tell me which one, which one appears twice. Okay. Let's see. Slide, bar, clip, bar, left.
So normal processing speed. This finally led us to the last two regions that we were really wanting to explore. I was convinced that the upper portion of the brainstem and the hypothalamic region was really critical. We tried to develop new access points in the third ventricle based on that thalamic injury that I had sustained almost 20 years ago. Let me back up, that our patient had sustained and what she had taught me. So we were looking for new corridors into the ventricular space, up into the hypothalamic region, using the same concept of tractography coupled with real-time neurophysiological monitoring with a completely conscious patient. We started to approach this region in the periventricular space. We created a set of corridors into the SLF region. We had done the posterior, now we focused on the anterior region. And we completely changed the access points of the Coker traditional point where we felt that that would transect the SLF. Instead, we moved the entry point into the superior frontal sulcus that was far more anterior, more medial in order to preserve this region. This led us to the idea of performing third ventricular surgery awake for patients, which we published a few years ago. So in this case, a large craniopharyngioma that we're resecting with the patient completely awake and conscious. And I want to emphasize that this patient has never been put down, no real sedatives, it's done through a block. And as we start to enter the region, you can see we do the septostomy, the patient's away. As we then start to approach the region of the fornices, as well as the medial bundles of the mammillary phlanal tract as well, the patients start to develop real-time memory deficits. We describe this as the concept of 3 strikes and you're out, with 2 changes in the patient's memory as assessed by a neuropsychologist in the operating room psychiatrist. We then aborted the case. And that created this concept of hypothalamic memory resilience and a proximal and distal bundle. And we've described that in some detail. And then finally, we got into this idea of applying the optics in the vascular space. That was the last area that we wanted to focus on.
Is now
and in this case, we're starting to do a large aneurysm in the middle cerebral complex using a robotic visualization. And the point I want to make here is the view that you're getting.
Distal middle cerebral artery and 2 branches through the optic tract and into the interpeduncular fossa.
So what you're seeing now is from an M2 to Lilliquist all in one view. This led us to a visualization pattern in the posterior, in the vascular world that I just couldn't go back from. So as I apply an M1 temporary clip, I can see the aneurysm, I don't have to refocus, and eventually I'm able to apply
the initial blade
and get a large volume of view across the entire base of the
mobilization depth of field. Microdissection technique can now be undertaken. The aneurysm is now gathered and manipulated with dissection under the trap. Both the proximal M1 and the distal M2s are simultaneously viewable. That allows for visualization without any need to change focal planes. This provides a critical view that allows the aneurysm to be secure, collapsed, and the clip is now closed.
When I close the clip, you'll see that I'll bring in the microscope.
Perception is now provided by
there's no issue of 3D.
The visualization as well as proprioception. Note, the in-focus volume of view provides a simultaneous visualization of the M1. The branches are checked for patency, and branch patency is confirmed. The conventional stereoscopic
look at the difference between a microscope view here, and I realized for the first time that the microscope tends to cheat to yellow compared to the view of a robot, which truly is, in my opinion, a more natural and appropriate view. The white matter looks white, and here you can see the transgression into yellow and the limited focus. And so that changed my pattern. So finally, how does this all come together? And this is the last case I'll show. This is a large AVM in the posterior fossa, in the region of the occipital lobe that then transgresses into the dominant hemisphere, into the choroidal fissure.
Malformation,
posterior.
The MRI scan.
So as we started to take this lesion on, we weren't sure how to deal with it. Its pedicle feeders were off of the P2, P3 region. It really brought everything that we've done in the last 20 years together. We started to do a cortical map of this region and figure out how to access it. When we decorticated the space, we were deeply concerned about the subcortical network here. We then peeled the subcortical network back. We knew that rather than going through the interparietal sulcus here, we could go through the parieto-occipital sulcus. We then peeled that back. And when we did, we found this region of the optic radiation, the region of the tapetum of the ventricle. We could access the space medial to it, created a 3D anatomic model, and then put that in the operating room. We did this through a tube and then cannulated this through the tube. The operating room now looked like this.
The targeted vessels. Note the color Doppler shows
we can see the AVM
devascularization
itself,
of this portion.
and then using the port, we could identify the pedicle of the AVM, isolate it. There it is, right down to the left ventricle atrium, using tritography to preserve the optic radiations, but also preserving the region of the vertical rami. And this is the real operating room, so you can have 2 surgeons working simultaneously together. You sure get a lot of bleeding. These can be easily managed with 2 surgeons working together. The AVM then comes out, and this is the patient's visual fields post-operatively that in fact improve rather than degrading. So if I were to wrap up my experience over the last few years, what we really focused on is the role of the patient teaching us anatomy, the anatomy then creating a demand for technology, and the ability to convert that technology into translational research has really been the key. There's no better example of that than my particular evolution in optics, where initially in 2010, I moved into an exoscope that was arm held, hundreds of movements mechanically each time, to 2015 that converted into a computer machine interface into an operating room that looks like this. Where are we going to go next? It's going to be completely dependent on learning from our patients and then demanding that the tech sector meet the needs that our patients are creating for us. And they've been wonderful partners in being willing to push the envelope to be able to see the anatomy in new ways, remembering each complication drives the next iteration. But Beck, I'm going to stop there. I've carried on for too long. So. Hello?
Thank you very much, Dr. Kassam, for an excellent presentation. So it really shows us that patients are our best teachers, but also we have to develop technologies based on their needs. So the question to you from me is that, where do you see the world of neurosurgery going from this point? So can you tell us what's the future holds for the field?
We're going to see an entirely new era in neurosurgery, Quebec, and I'll tell you why. We're the last to adopt technology of any specialty. So when you think about our technological adoption, we're slower than cardiac and general surgery. The optical imaging we use today is so much slower. The cardiac guys are faster. Have you ever wondered why? And the answer is because the risks in our specialty are higher, so it's harder for us to tolerate risk. That's the fundamental reason why. But when you hit an inflection point, when people realize the only way to reduce risk in a meaningful way is by embracing technology, we will move faster than any other specialty in the world because the returns are greater. In order for us to do that, we're going to enter an entirely new era of multidisciplinary partnerships. So I don't mean in medicine. It's not going to be ENT and neuro coming together like we did 20 years ago. That's already happened. Neuroradiology, et cetera. We're going to move into an era that is the embodiment and the reflection of the SNBMT. We're going to look like that as a specialty. So what do I mean by that? We already start working with each other in our own medical specialties, right? The only way we can make meaningful change and stop a glioma from killing patients, or Alzheimer's from maiming patients, or MS from creating morbidity, is we now need the tech sector to embrace the work that we're doing. We now need the economic sector to be able to embrace what we're doing. We need the political sector to realize that the single biggest threat to population health and the economy in the world today is degenerative health, neurosciences. Right? The single biggest threat is the aging population and neurocognitive care that will come in the emerging world from this. And people are realizing it. So what we're going to start to see is the conversion, and I believe this in all my heart, of knowledge into capital gains and value for the political world, for the tech world, which will ultimately translate into value for the patient.
Excellent, excellent. Well, we look forward to collaborating with you. This was an excellent presentation. Unfortunately, we are gone over time, and we need to have our second keynote speaker, Dr. Sadowsky, come up to the podium. And thank you very much, Dr. Kassam. Have a good day.
Thank you. Bye-bye.
It is a great honor to introduce you Dr. Cristina Sadowsky from Johns Hopkins University. She is one of our board members, just joined our board, and we are delighted to have her speak about rehabilitation and the future of rehabilitation and how can we actually shape the future together, right? So, sure. Pleasure.
Thank you for having me here. Okay, let's see. So my controls are? This one, okay, good. So good morning. We are 3 days smarter, is BMT smarter, and at least in the United States, we are springing forward, for better or worse. Dr. Kassam asked me to talk about neuro-rehab, and my disclosure is that I am a spinal cord injury medicine specialist, but the spinal cord is part of the CNS, the central nervous system, so, okay. So I think I can wing it when I'm talking about the brain too. I have no real conflicts of interest, no other disclosures. I am an academician and a program development, and I'm just learning right now from SBMT how to partner with technology and companies. My goal is to present this rehabilitative and surgical applications that are targeting neuroplasticity. These interventions are actually used in clinical setting right now in the context of a damaged CNS. And I'll start with the fact that there is a misunderstanding of quality of life. When you are on the acute frontline neurosurgical side or the emergency department physician side, paralysis comes with something that feels like a lifelong sentence. And multiple surveys show that physicians underestimate the quality of life of individuals with paralysis. When I made the transition from an interventional internal medicine physician to a spinal cord injury medicine specialist that treats chronic paralysis, I realized that my patients have actually an incredible amount of strength and stamina, and their quality of life is nowhere near what we imagined. The data over there says that us as physicians think that they don't live a good life, and they do. And in fact, that's how I got so excited about doing what I'm doing and trying to improve function, because I am learning every single day what a person can do in the context of being given less. Spinal cord injury per se was called a death sentence. General Patterson, after the Second World War, was in a spinal cord injury, was in a motor vehicle accident, had a cervical injury. He treated no treatment. He elected no treatment. So he died because he said, no, I don't want to live like this. So looking at the fact that there is this discontinuity, disconnecting between who we are as healthcare providers and who we're treating, and learning, as Dr. Kassam mentioned, from our patients, I try to go into the fact and try to dissect what can I do to actually change outcomes. Injury consequences in traumatic brain injury or in spinal cord injury are the same. So cell injury, cell death, synapse connection disruption, axon damage, the tissue reactivity, astrocytes, inflammation, the penumbra, which is the area of tissue near the injury where there is the potential to intervene with some factors, with some agents, pharmacologic or neuroplastic, in order to save some more cells. And then we have to deal in the long term with scarring and cystic formation. And at the microcellular level, we have this depolarization with ionic failure, and the cascade, the excitotoxic cascade, and then associated vascular changes. So that all is the basic of my transition to what can I do on this side after you all brilliant surgeons are doing your work. What can I do to continue it? Because while most of the surgeries have really good outcomes, a lot of the trauma that I deal with does not. And also spinal cord injury and stroke and traumatic brain injury have, well, there is a non-traumatic component that we can address and use the same interventions of neuro-rehabilitative intervention. So rehabilitation usually has a preventive role, prevention of complication, the range of motion, the saving the soft tissue, preventing bowel and bladder problems, and so forth. But we also, as rehabilitation specialists, play a role in the post-acute part, and we guide prognosis. And the ones that choose to, we go with restoration of function, not only the daily function, but restoration of function through improvement of neurologic function. And here, that brings me to neuroplasticity, because in the space that I occupy, yes, I'm interested in doing restoration of daily function, but not compensatory, but restorative. So I want to get better function because the neurologic function is improved. So Kleiman Jones had 10 principles of neuroplasticity, which probably you've heard about 2 days ago in the keynote speaker. But I'll remind them to you because you've heard some of them. Use it or lose it. So it's the failure to drive specific brain function can lead to functional degradation. Use it and improve it. If you train, it's going to get better. That's the point of me practicing piano about 30 minutes a day. Specificity of the practice. If I want to play the piano, I'm not practicing the violin. Repetition matters and intensity matters. You can repeat 3 times and not be enough, but if you repeat 10 times, it will be. Time matters. There are different forms of plasticity that occur at different times post-injury. So there are different interventions that are being started according to if you're in the acute, subacute, or chronic period. Salience matters. The training experience must be sufficiently salient to induce plasticity. And I cannot stress enough how important it is to combine the salience, the time, and the specificity together. If you want to be a good pitcher or professional pitcher, you cannot just practice 30 minutes a day and do cardio. You have to practice your task. Age matters, and I'm going to take a little bit of an issue with that because physiologically we are aging a little bit slower these days, and that is reflected in our actually functional capacity. So we have multiple individuals that are in their 70s and 80s and still run marathons. But in order to get there, you have to have the physiologic background and maintain it. And then we have transference and interference. Plasticity can be, so good plasticity can be transferred to other tasks, but bad plasticity can interfere with tasks. Okay. I use activity, and when I say activity, it involves a lot of interventions, including exercise or stimulation of the CNS in order to improve the neurologic function. And why do I do that? Because, well, activity promotes synaptic connection, it promotes new cell birth, and of course, it enhances function. I believe that there was a previous speaker that, and I think Dr. Yamamoto also did some work into new cell births in the CNS. So there is the animal level proof that there is new cell birth in adult animals. There is also some human level proof that there is new cell birth in adult brain. That's Some people are still debating that part, but anyway, we're thinking about the hippocampus and the olfactory system that have the most evidence that there is new cell birth in the CNS. I did mention that not rehabilitation is created equal. Traditional is use anything that you have left and make do. Activity-based is improve the function, the neurologic function, thus improving the day-to-day function. So what are some activity-based interventions meant to alter neuroplasticity? In traumatic brain injury, we have neuromodulation through CNS stimulation, and we can use transcranial magnetic stimulation or direct current stimulation. In stroke, while we can still use TMS and TDCS, we also use the forced use or constraint-induced therapy. And in spinal cord injury, we use activity-based and spinal cord stimulation. And actually, the spinal cord stimulation can be combined with cortical stimulation or peripheral nerve stimulation in interventions called dual stimulation. Neuromodulation and traumatic brain injury. It has been shown to improve motor performance. Transcranial direct stimulation can be used to both prime the intervention or as an add-on approach to increase this responsiveness of the selected cortical regions that we want to target. So it can improve motor function, like balance, stride length, and in gait cadence and velocity. Deep brain stimulation has been shown to improve motor control, both in motor control disease that's related, like Parkinson, but also when we're dealing with motor impairments resulting from brainstem injuries like stroke. Repetitive transcranial magnetic stimulation, it's non-invasive, uses the figure 8 stimulator, magnetic field that delivers a low-intensity electrical stimulus to the brain. In the figure 8 stimulator allows you to concentrate the delivery into specific cortical areas that result in improvement of motor function. So I don't have a video like Dr. Kassam had, but you put a figure 8 coil and you can make somebody's finger move. From that, we're going to move to, or add, the constraint-induced movement therapy that has been the most studied rehabilitation intervention in the last 20 years in stroke. Basically, what we do, we limit the activity of the compensatory activity of the good hand or the good leg, and we force the residual limb, the one that has decreased function, to perform in a task-specific manner the motor activity that is needed. There is strong evidence that it favors it and improves motor function, especially at the arm level. And if you all recall, seeing patients with the hemiparesis related to stroke, they have an abnormal gait. We have a lot of other intervention to improve gait, but the hand function is something that we're still striving with. So this is forced use or constraint-induced. I like to use forced use because I'm an activity-driven individual, so constraint-induced makes me a passive receiver, but it's the same principle. Okay, can you help me with that? Because to start that guy. Okay, we're moving to spinal cord injury. If you are you're going to see over here an experiment in which we have Bud that has 2 motor cortical strip implants and 1 sensory. And he is using implanted EEG to control robotic arms in order to perform a functional task. Now, this is the result of 15 years. Is this moving? I don't think it's still moving. Anyway, of a 15 years program that started with the Hopkins lab. The first patient that was shown to the general public was a University of Pittsburgh patient that fist bumped President Obama. This is the next iteration. So it has both a motor and sensory control. So Bud is actually able to feel and differentiate different textures by using the sensory implant. So the first implant was motor in just the motor strip. Now we move to 2 motors and 1 sensory. We're still enrolling for that. So if you have anybody that is that has a high-level spinal cord injury or a brainstem injury, we use both traumatic and non-traumatic subjects. We are definitely enrolling 1 person at a time, though, because it is a very time-intensive stimulator study. It takes about a year. It takes 3 days a week of training, being in the lab, but it has wonderful functional and neurologic function improvement results. Spinal cord stimulation, and I might talk a little bit about acute intermittent hypoxia at the end, are the 2 neuroplastic interventions that I'm most excited when it comes to restoration of neurologic function in spinal cord-related paralysis. And the spinal cord stimulation can be done transcutaneous. And the transcutaneous intervention, it is truly easy to do. It is done in clinical practice. In fact, in my clinic, I apply it to every single patient that has a spinal cord injury, both complete and incomplete. Now, it doesn't work in everybody, but what it does, it raises the activity. It excites the neurons below the level of injury. We apply it both in the lumbar area for paralysis or in the cervical area for cervical injuries. And while the stimulation occurs, we are introducing we're introducing voluntary activation of the upper limb for cervical injury or the lower limb. About 50% of individuals will have voluntary activation. If that occurs, we're using a robotic, either a robotic walking system or a robotic arm system like Armeo, and enhancing the minimal voluntary activation in a finger or a hand or long toe extensor, we're enhancing it with motor training. And we deliver this in clinical rehabilitation day in and day out. So this is not, something that it's only done in a clinical trial. There are numerous clinical trials that are ongoing, still recruiting, but my point is that this can be done low cost in a clinical practice. The epidural spinal cord stimulation and the magnetic spinal cord stimulation are 2 other ways of intervening. The epidural spinal cord stimulation, let me see if I have okay, can we make that one? Oh, what am I doing? Let's make that. I'm not doing anything, that's you. Can you make that play? Double click on that. Oh, please. I know this works. Anyway, while he's trying to make the YouTube video work, this is the work of Greg Cortin, who published the first 3 patients in 2018, in which he took 3 individuals with complete paralysis that were chronic injured and in a chair, implanted the stimulator into the lumbar area, and after some rehabilitation.
Over the past 30 years, various research groups have stimulated the spinal cord electrically to restore walking after paraplegia. And after intense rehabilitation, a select few individuals were able to take a few steps, but only with electrical stimulation. And nobody understood why. My team took the time to understand the science behind it, which allowed us to stimulate the spinal cord as the brain would do naturally. And the result was completely unexpected. After several months of training with electrical stimulation, our 3 participants were able to activate their previously paralyzed muscles without electrical stimulation. I mean, they could even take a few steps over ground, hands-free, without any support. For me, seeing this recovery was amazing.
We can stop there. Okay, so those results, those were the first patients implanted in 2018. 2022, February, there was the second group of another 3 individuals that had similar results, but without the 5 months of intense treatment, because what Dr. Cortin is doing right now is optimizing the epidural implant, so it is on and off switch. Now, he is not the only one doing this work. In fact, in the United States, Louisville, Dr. Susie Harkema had published the first report in 2011, and she continues enrolling individuals with complete paralysis that are involved in Medtronic stimulator implant, and Mayo Clinic is doing the same thing. This, not only that there is motor function improvement, but there is autonomic function improvement in this individual. So bowel, bladder, sexual function are all reported to improve. And again, this is simple neurosurgery for all of you guys. It's just an epidural. In fact, in the United States, we are using the Medtronic pain stimulator. That is what is implanted. And the complicated process is to program the 168 spots because they're personalized and individualized to each subject. Can we go back? I don't know if I'm done with, I think I mentioned that there is the magnetic stimulation. Oh, let's see. Oh, I actually can go back on my own. Yes, so we have the magnetic spinal cord stimulation. This is work that uses the low intensity magnetic stimulation by applying the same principles of neurostimulation mostly in the thoracic area. This is still something that we are in the process of figuring out the clinical results. So EMG-wise, that is a lot of activity, voluntary activity, but from a functional clinical point of view, that is we're still working on how to improve the day-to-day function. And then we can do the paired associated stimulation, in which we take 2 out of 3 of those. This work, again, is ongoing and is done at clinical level trials. It is way past the animal model. Okay. As I mentioned, there are other effects of spinal stimulation, and with the transcutaneous spinal stimulation, we have sensory and autonomic nervous system function improvement and spasticity management. With the magnetic one, bowel, bladder, respiratory muscle, and spasticity, and the implanted one, the epidural, improvement in pain, bladder and bowel, and blood pressure, CVS function. In fact, I stopped using in my clinical practice pharmacologic intervention to treat autonomic dysreflexia because I'm using transcutaneous spinal stimulation, which modulates the the autonomic nervous system response. So my patients, not only that they're more conditioned because they do 3 hours of therapy, not necessarily always with me, they do it at home, but they also use the transcutaneous spinal stimulation, so their low blood pressure is better, and their high blood pressure never gets to be in the 200s, risking stroke. And then I'm just going to mention acute intermittent hypoxia because I said that I'm really excited about this. It is, again, a very simple intervention. It's delivering repeated episodes of 9 to 10% hypoxia, so alternating room air with hypoxia in a seated position. So hypoxia 9 or 10% is like climbing Mount Kilimanjaro, basically. I wouldn't deliver it for individuals that have significant respiratory disease or cardiovascular problems, but everybody else is eligible. After seated 30 minutes of intervention of alternating this, I'm following up with motor retraining, which is, again, technologically driven, either robotic upper limb or robotic gait training. And after 6 to 8 episodes, so this is 6 to 8 visits of an hour and a half of rehabilitation, in individuals with incomplete spinal cord injury, there are improvement in walking endurance and walking speed. So it only takes basically a week or two, and you make their gait better, their hand function better. It's really can be delivered in the clinical practice, and there is really good science that backs it up. This has not yet been tried in complete injury, which is what I'm working on right now. And I think I'm done. I have to thank my patients because I am a clinician with some applied science. And like Dr. Kassam before, I learn each day from each one of my patients, and because we don't cure paralysis yet, they're my patients for life. So whatever I do today, I have to be responsible for tomorrow and 10 days, and 10 years from now, and even to their children. So that puts a lot of pressure and makes me be a very hardworking woman. So thank you.
Thank you very much.
I'm going to try not to fall off the stage. Okay.
Appreciate it, Dr. Sadowsky, for your amazing presentation. Any questions from the audience? Well, I have one question from you, and that is, how do you see the future of the rehabilitation? Is it combination of stem cell, robotics, and other technologies? So you could, elaborate. You can come up here again. Yeah, please. Sorry about that. Yeah.
I just say that I like activity, so
Yeah.
let's see. Is this no? Okay, I am not simple-minded, but I like simple intervention. So I have the ABCs: activity, biologics, and computers. Now, the computers obviously is the technology, but it sounds better ABC than ABT. So activity, exercise, following the principles of neuroplasticity are essential. And because individuals with paralysis have low level of activity, just doing what we're doing for ourselves, individuals, able-bodied individuals, is good enough. But if you can add extra, not subtract, never subtract, and the injury does the subtraction. So we need to restore the activity at normal level, and I don't know, whatever whatever study you're looking at, the latest one that I read was that 6,000 to 8,000 steps a day is just a sweet spot. I don't know. I do a lot more than that because I like activity. Biologics. I have a whole spiel about biologics, but they have a role, and I feel bad that we were robbed in the scientific community of about a decade of stem cell research. But they have a role, and we just need to figure out how they work and what they can do. And then technology, and that's why I'm here.
Thank you. Thank you. Thank you. Thank you very much, Dr. Sadowsky. With that, we'll go to a short break, and the parallel sessions will start later. Thank you.